Thank you, everybody, for being here tonight. As I said earlier, this is an MS Views and News program. We have not been to this area, I think, since 2018 or 2017, but I'm really feeling very fortunate that we're able to get back here again. As I mentioned earlier, there was a lady sitting out there in the audience that got MS Views and News to first come here about 15 years ago, and that's Karen Hart. She was a big-time support group leader back then, and we welcome her for doing what she does. Tonight's program, so I don't sit here rattling around all night. But tonight's program, we are sponsored by TG Therapeutics and Novartis, Sanofi and Genentech. And I hope that we could all give them a round of applause. Thank them for being here. Thank you. Thank them for supporting our program, because it's not possible for us to do these programs wherever we do them in the United States. When you guys last saw us, we were primarily only doing programs in the southeast portion of the United States. Now we're doing 40 programs a year in person, from coast to coast, east to west, north and south, and all around town, all right? So I want to thank everybody that is involved with our programs for doing them. Dr. Baker, I'm not going to introduce him because you all know him. He could introduce himself. Thank you.
Wonderful. Welcome, everybody. Thank you, Stuart. A few disclosures. One, I withdraw my consent to be, I'm kidding, no. Second disclosure is Stuart has not seen this presentation, so he is completely absolved of what is to follow. And I probably should say then, the views of MS Views and News are not necessarily the views of this presentation, or the other way around. So that's and then just really, I just want to thank you all for coming out. I recognize a lot of you out there, and I feel like we're friends and family. And I mean, I can even tell who's changed their hair color, who's lost weight, who looks more tan. So it's just wonderful to be among friends. That makes it easier. The picture that was up there before, that was only taken about 2.5 years ago. And I realized that I look much older than I do in that picture. So my beard is gray. I've lost more hair. So I'm aging. The Views and News have provided me with this slide advancer, which is a flip phone equivalent of a normal slide advancer. There's big buttons, so they already think that I'm aged now too. So usually it's like there's all these small buttons. And so I'm going to start this presentation. So this is MS. Living with MS in the golden years. And I had a wonderful patient. She didn't have MS, but she was the oldest patient that I ever cared for, and she lived to be 102. And she couldn't hear, and she had a memory problem. That's why she came in. And every time she came in, she would recite this poem for me. And I'm gonna read it to you. I'm gonna recite it for you. Every single time. And she would say it at the top of her voice. The whole office could hear her. So this is a poem entitled The Golden Years. The golden years have come at last. I cannot see, I cannot pee. I cannot chew, I cannot screw. My memory shrinks, my hearing stinks. No sense of smell, I look like hell. My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my ass. That was wonderful. And thank you, Jeff, for saying ass earlier. So now I don't feel so inappropriate. So the next thing I thought about is, we all live in Southwest Florida here, and I've been practicing here for 23 years. And so when I started treating and caring for patients with MS here, my patients already started out older. And so I'd go to these meetings and I'd talk with other neurologists, and they'd say, well, how old is your oldest MS patient? And I'd say, well, 84. And they say, no, that's impossible. There aren't any 84-year-old MS patients. And I have a colleague up the street in Sarasota, and he takes care of older people with MS too. And when we introduce ourselves at meetings, he'd say, I'm in Sarasota, and I have generally an older population. And they'd get to me and I'd say, well, I'm treat MS in Naples, Florida, and I take care of the doctor in Sarasota's patients' parents. So I'm taking care of the grandparents. So this gold bar here, I don't go to the beach much, but you can imagine being in Southwest Florida, and you go to the beach and you're sitting in your beach chair, or you're laying on the towel and you're relaxing, and maybe you have a cocktail fruity beverage with a little umbrella in it, and you're running your feet through the sand, and all of a sudden your toe strikes something. You stub your toe and you look down and you fiddle around, you dig, and you find this amazing gold bar with all these markings on it, which look like maybe it comes from Spain. It was lost in a shipwreck, and now it's washed up on the beach, and you found it in the sand. And so, I've asked people, when you find this gold bar, what's the first thing you do? What's the first thing that comes to mind? What do you do? And the majority of people say things like, oh my gosh, I clean it off. I look around, make sure nobody's looking. I put it in my pocket. I search Google. I see if there anything matches. I take it to an appraiser. I find out how much money it's worth. I weigh it. I might bite it and see if it's real. And so you hear all these answers. And how many of you out there would do similar things? Yeah, raise your hand. So, a lot of people would do that. I see Tom raise his hand. Dr. Nate, I'm sure that's what he would do. Now, if you ask Stuart, because Stuart's a very analytical, critical guy. If you ask Stuart what he would do at that point, what would you do, Stuart? You Google it. Okay, he's tech savvy. Okay. So, Stuart, you're wrong. That's not the first thing you should do. The first thing you should do is you should look for more gold bars under your beach chair, right? And that's where this talk kind of centers, is that when you have MS and when you're getting older, you don't just assume that it's that one bar there, that one gold bar. And oftentimes patients will come to me, people with MS will come to me, and they'll say, well, I have this symptom, or this is going on. And I talked to my doctor about it, and they said, well, it has to be your MS. How many people out there, if you have a symptom, it has to be the MS, can't be anything else? Well, that doesn't happen as you get older. Things get more complicated, other things occur, and you have to be vigilant and pay attention to these other things. So just remember that. So this is our agenda tonight. So we're going to look at how does MS change over the lifespan. The MS that you get, and Jeff alluded to this, when he had that MS 25 years ago, he was told certain things that were going to happen to him. There was a prognosis there, and he made a conscious decision to alter his lifestyle and alter the course of his MS. MS can vary, can change, it can morph throughout one's lifespan. So the MS that you get when you're 18, 19, 20, or in your 30s isn't the same MS that's happening, the same pathology that's happening in your 40s, 50s, and 60s. And then we're going to look at what ages are affected by MS. And there's been some changes with that too. And then how does age affect MS? And then, so what? What can we do about it? We can't stop the clock, but there are some things that we can do to help ourselves. And it's very complicated. And this slide just sort of sets up some of those complexities. So we know multiple sclerosis is a complex immune-mediated disease, and it affects the central nervous system. So the optic nerves, the brain, brainstem, spinal cord. And so you'll notice there that I don't say that MS is a neurological disease or a disease of the central nervous system. It's a disease of the immune system where the target is the central nervous system. And there's two parts to this. There's an inflammatory component where there's an infiltration of inflammatory cells that cause damage to the fatty protective sheath or myelin, damage to the nerves, to the neurons, to the axons. But there's also, and very early on, there's a neurodegenerative component. There's a process that occurs that drives disability accumulation. So not only can the acute inflammatory component of MS drive disability and cause worsening of neurologic function, but this neurodegenerative component can also occur early and lead to worsening problems later on. And the symptoms are just vast. There's myriad symptoms. So there's all sorts of things that can occur in MS depending on where this damage occurs. Well, aging's not unlike MS. As you get older, there's an inflammatory component. So there's this strange low-grade inflammation. We call it inflammaging. It can affect multiple organ systems, GI tract, brain, joints, muscles, blood vessels, heart, etc. And it can alter the way that you can respond to infection and the way that your immune system works. So not only is there a low-grade inflammation that's going on, but when you need that immune system to kind of step up its game and fight off infection or protect you against certain things like cancers, it doesn't have the ability to do it because it's busy doing this aberrant inflammaging process. Then as we get older, the immune system, on the other hand, loses its potency, loses its power, and we call that immunosenescence. And then as you age, you develop other things. We call those comorbidities. So other health and medical problems occur which affect the way that you experience symptoms, but also affect the way that multiple sclerosis behaves and the progress or the progression of disease. This is a very common slide. So I think it's hard to do an MS talk without having a slide like this. And I tried to simplify it. So these are the mechanisms that occur in MS. So here you have time. And these green arrows here represent MRI activity or new lesions that are developing. And then in dark blue here is neurologic disability. So the higher the bar, the more disability there is. And this lighter gray, I think I'm a little bit colorblind, so sometimes I don't know what the colors is. This represents what we call neurological reserve or reserve capacity. And that correlates with volume of the brain, volume of the spinal cord, and over time it goes down. And so there's a few mechanisms that are occurring. So early on in MS, there's MRI activity and there aren't symptoms that are present. So either the brain and spinal cord, like in pediatric MS, have the ability to adapt and compensate such that symptoms don't emerge, or those lesions haven't hit places in the nervous system that correlate with symptoms. And we call those clinically eloquent areas. So a lot of things can occur without any symptoms happening. And so if you were to do an MRI for reasons unrelated to MS, so maybe somebody has headaches or maybe somebody's in a car accident and they fall and hit their head, we will see in certain individuals, we'll see things that look just like MS, but that first clinical event of MS hasn't happened. And we call that radiologically isolated syndrome. But there's also a clinical stage here before that first attack that we call the MS prodrome. And many of you out there, because I've talked to you, and when we go back in your history, you say, well, I was diagnosed when I was 35, but I knew something was wrong. I had optic neuritis when I was 35, but I knew something was wrong for 10 years prior to that. I didn't feel right. I had pains. I had nummy tinglies. I was depressed. I was anxious. I had sleep disturbance, heat intolerance, fatigue. That's the prodrome of MS. So MS will start before the onset of the clinical symptoms. From the very onset of that prodrome, there can be cognitive issues and brain atrophy and this progressive neurodegenerative component, this very sneaky process that occurs. Now, most people with MS start out with a relapsing form of MS where they will have an attack of neurologic disability followed by a relative period of recovery. And that can be associated, if you look at the right spot, that can be associated with an MRI lesion. So each attack, there might be an MRI lesion. But over time, there's sometimes a lack of recovery. So an attack will occur, but that individual won't get back to their baseline neurological function. And so when that happens, we have a term for that. We call that RAW, or relapse-associated worsening. But even in between those attacks, there can be progression of disease and accumulation of neurologic disability without those attacks happening, maybe not even with MRI activity. So we have a new term for that, which we call PIRA, or progression independent of relapse activity. So this is this sneaky neurodegenerative component, this sneaky low-grade inflammation that is happening separate from this relapse activity and acute inflammation that we don't have a great handle on therapeutically yet, but we're learning about that. So over time, disability accumulates. Some of that has to do with that loss of neurological reserve that is occurring. So when this occurs, we call this secondary progressive MS. Starts as relapsing form, but then goes on to secondary progressive. It can be with or without disease activity. And then some people have a sneaky MS where it starts with a neurological problem and then it just slowly gets worse with time. And that we call primary progressive MS. Most patients have relapsing forms early on, and then untreated will go on to develop secondary progressive MS. And then fewer people have this primary progressive multiple sclerosis. So we think about, Jeff mentioned that when he was diagnosed, there were only 400,000 people in the United States with MS. Now it's ballooned to over 1 million. If you look worldwide, probably over 2.5 million people are affected with multiple sclerosis. What we're seeing now is that in areas where we didn't see a lot of MS, we're seeing more MS. We're seeing diagnoses in populations where traditionally we haven't thought about MS. We've always considered MS to be more in Caucasian people of European descent. Now we're seeing that in the Hispanic population, more multiple sclerosis. One of the fastest, or the majority of new diagnoses occurring in our African American individuals. And so we think about MS as a young person's disease, and it is diagnosed within a certain age range. Does anybody want to take a stab on the age range in which MS is typically diagnosed? Yeah, 20 to 40, 20 to 50. Yeah. So MS is typically diagnosed between the ages of 20 and 50. So this is a young person's disease, right? This is a disease that young people get. So how about in the United States? And this is a little bit of a tricky question because you have to wrap your head around it. What is the age of most people living with MS? So if you take everyone diagnosed with MS, what kind of age range are the most number of people living with MS? And I'm not going to make you guess it, but I'm going to throw up some options here. So just a quick show of hands. You think under 18? Most people with MS are under 18. No. How about 18 to 25? Most people with MS, 18 to 25. All right. No takers there. 25 to 34. All right. I heard one. Yeah. 35 to 44. Okay. A few more hands up there. 45 to 54. Okay. A few more hands. Now we're getting into my age range, 55 to 64. Okay. Few less people. 65 to 74. No takers for that. 75 plus. All right, one person, okay, 75 plus. That's good, that's good. Would you believe that the majority of people in the United States who have MS living with it right now are age 55 to 64? So as the population ages, that's the prevalence is highest in that group. Now, do you think the next highest age group, do you think it's younger or do you think it's older than that? All right, so I set you up for that. You're absolutely right, older. So the two main groups that are occupied or have the most number of MS patients is 55 to 64, 65 to 74. The next one is in the 40s, like 35 to 40 range. So this is a hot topic. This is important. You guys here in this room that are 55 to 74, this is the majority of patients living with MS. And so we know from all our clinical trials and medications that we have, and when we study MS, usually those trials include people 18 and the cutoff is 55, sometimes 60. But we need to learn more about how to treat people with MS, how the medications affect these individuals. So every conference I'm going to now, 5 years ago, there weren't any courses on older people or older individuals living with MS. Each time I go to a conference, there's now one or two more courses the next time looking at this as a topic. So this is a very important issue to discuss. So age of onset. Age of onset is important. So pediatric MS, I take care of kids with MS. and they will have I've seen MS kids at age 4 up to age 17. When we see MRIs, they'll have a lot of disease activity, a lot of inflammatory activity, and their neurologic exam can be completely normal. It's remarkable. These young brains are just so malleable and adaptable and have all these built-in mechanisms to adjust for this damage that it really resonates with me how amazing the nervous system is at that age. Then the next age group, we call it adult MS, is ages 18 to 49, and that's that typical age of diagnosis, right? Now, there's a term, and I'm not liking this term very much because this is my age range, but we call this late onset multiple sclerosis. So the diagnosis, not symptoms, but when you are diagnosed with MS at 50 to 59, and this is even more insulting to me. Very late onset MS is greater than 60. So more older people are being diagnosed with multiple sclerosis, and when we see someone over the age of 50 with symptoms of MS and MRI findings, it's very important to think about other things that might cause that. So you have to look for MS mimickers. So you have to be very careful to rule out absolutely everything else that could potentially present this way. Now, the older you are at onset, so if you have late onset MS, you're at higher risk for developing secondary progressive MS, and you're at higher risk for more disability. And that sort of makes sense because you're unlike the pediatric patient or the young patient with this adaptable, malleable brain. At older ages, the brain doesn't heal as fast, your remyelinating potential isn't as great, and you have lost some of that neurological reserve. Now, you might say, well, why is it that this is occurring? Some people say, well, there are better diagnostic tools available. We're more aware of multiple sclerosis as a disease. Neurologists are being educated about the diagnostic criteria, so we're picking it up more. But if you correct for all of those factors, we're actually just seeing more MS in this age group. So something's happening environmentally that is increasing the incidence of MS in this older population. In certain European countries, we can track this very well. And maybe 10 years ago, 1% of patients had that late onset MS greater than 50. Now it might be as high as 10% of people being diagnosed with multiple sclerosis have late onset or very late onset MS. So what are the symptoms of MS? So I'm going to set it up this way. And Jeff alluded to this, but we think about MS symptoms as visual changes like optic neuritis, usually unilateral or one-sided visual loss. It can be painful, loss of color differentiation, double vision as a visual symptom, weakness, loss of power, sensory changes, numbness, tingling, balance problems. Fatigue is a big part of MS, that overwhelming fatigue that occurs. Cognitive changes, so impaired attention, concentration, memory. Urinary symptoms, so frequency, urgency, incontinence. Bowel issues, either the bowel stops working as well, or there can be bowel incontinence. Heat intolerance, sexual problems, pain, muscle tightness and spasticity, mobility issues. Up to 1/3 of patients with multiple sclerosis will report speech and swallowing difficulties, under-recognized symptoms. And then related to treatment or even disease, there can be infection risk. So if you have issues with urinary retention or bladder symptoms, you may be more prone to urinary tract infections. Certain medications can lower your immune response, and you may be more prone to lower respiratory tract infections, urinary tract infections. The pain can be very prominent in multiple sclerosis too, not only from spasticity, but there's a condition that we call the MS hug, which is not a friendly kind of hug. It can be around the abdomen, around the chest, but it's this tight, squeezing boa constrictor paroxysmal, comes and goes, severe discomfort, jaw pain, trigeminal neuralgia, these shooting lightning-like pains in the jaw. So those are the symptoms of MS. What about symptoms of aging? What kind of symptoms do you get with aging? Just sort of look at that. But I just copied this slide and just changed the title from symptoms of MS to symptoms of aging. So you can have visual changes, right? So what happens is your visual acuity decreases. If you've had MS and you've been treated with steroids, corticosteroids throughout your life for relapses, that puts you at risk for early development of cataracts. So that's important to remember. Weakness, as you get older, the muscles become weaker, especially if you don't do your resistance training. We have a term for that, sarcopenia. So anything in medicine that's penia means lack of. Sarco is the prefix for muscle, so sarcopenia. We saw a wonderful demonstration of balance problems related to, Jeff said, proprioceptive abnormalities. And that's the ability of your feet and your peripheral nerves to talk to your brain. And all of that has to travel up through the spinal cord. As we get older, our nerves don't work as well. And you're putting that on top of proprioceptive challenges that already exist with multiple sclerosis. Fatigue happens as you get older. Is that fatigue related to a sleep disturbance? Is that fatigue related to medications that one might take for other age-related medical problems like hypertension? Is a fatigue related to a cardiac problem? So exercise intolerance, could there be cardiac disease there, or maybe some lung disease, some obstructive pulmonary disease? Cognitive change is big. As we get older, there are changes in our processing speed, our ability to recall things. As we get older, for whatever reason, guys will have urinary frequency, nocturia, can't get the urine out due to prostate problems. Ladies will have symptoms of incontinence, either stress incontinence related to pelvic floor weakness, either related to pregnancy and having children. Hormonal changes that occur as we age can affect the urinary function too. Bowel constipation, incontinence, hormonal changes, either menopause or, as I call it, manopause, can affect heat tolerance. Sexual problems. If you just listen to the radio and you look at your Facebook feeds and things like that, it seems like everybody has sexual problems. And so as we get older, pain, neurogenic pain can occur, musculoskeletal pain. Don't assume that your MS hug as you get older is a MS hug. So, I've had patients experience that, and they end up in the emergency room, and they have a widowmaker and need a stent in their left anterior descending artery. So, as you get older, you need to think about cardiac issues. Muscle tightness comes with age. Mobility issues come with age. As Jeff was talking, I remembered that riddle. That what animal walks on 4 legs in the morning, 2 legs during the day, and 3 legs at night? Man. So you crawl in the morning, you walk in 2 legs in the middle part of your life, and as you get older, you're using 3 legs, so you're 2 legs in a cane. Speech, swallowing difficulty, and as you get older, you're at risk for infection. So I can't focus on all of those today. I'd love to, but we could take each one of those topics and compare and contrast the changes in MS and the changes in age and how we differentiate that. I picked 3 things, mostly because Stuart told me that I had to do one of these, and I'm ignoring his other one. But we'll look at cognitive changes, and that was brought up earlier too, and I think that's important. And then infection risk and mobility issues. So preserving function of the nervous system depends on several different compensatory mechanisms. So number 1 is what we call neurological reserve. So what is neurological reserve? So that is just something that you are born with. So there's nothing you can do to change it. It was given to you. It's genetically encoded, and it's directly related to the total volume of the brain or the size of the brain. And so you can calculate what that neurological reserve is by measuring the internal circumference of the skull. And so the bigger your head, the more neurological reserve you have. And so I have a small hat size, so I'm out of luck there. So it's that total volume of the brain, total number of neurons that you're born with, and the total number of connections. And this neurologic reserve differs within the nervous system. There's different structures. So not only do you have your total brain volume, but there's also the volume or the size of the outer ribbon of the brain. We call that the cerebral cortex, the cerebral gray matter. There's a deep gray matter structure called the thalamus. That's important too. That has a reserve. And then there's a reserve within the optic nerve. It's a very resilient structure. It has a lot of reserve. And then there's also spinal cord reserve. And so that really tells us or helps us maintain neurological function when there are threats or damages to the nervous system, like occurs with the inflammation and the neurodegeneration induced by multiple sclerosis. Then there's a second type of reserve. We call that cognitive reserve. And the cognitive reserve is something that you build through time, usually up until the age of 50. And it's related to your educational level. It's related to your life experience. So it could be your work experience, it could be your travel experience, it can be cultural experiences, and that is something that develops. It has something also to do with your vocabulary. So the number of words that you know by age 50, your vocabulary, predicts your cognitive reserve as well. And we all talk about remyelination now. That's the next step in multiple sclerosis therapy. How do we remyelinate? How do we heal? Well, we have an inherent capacity to remyelinate. So whenever there's damage to the nervous system, that inflammation will trigger a response that results in a healing process or remyelination. Excuse me. As we get older, that remyelination capacity is impaired. And so that has an impact on those compensatory mechanisms. So the normal changes in neurologic reserve, so the brain atrophy rate, so the brain shrinkage rate has been calculated. And for someone who does not have MS, that brain atrophy rate is 0.3% per year about. And in untreated multiple sclerosis, because of this neurodegenerative process, because of this push and pull with the inflammatory process, in untreated MS, that atrophy rate is 3 to 5 times normal. And so you're looking at rates of 1 to 1.5% per year. So if someone told me, hey, you're going to lose 1% of your brain volume per year, that's going to worry me. So you look at 10 years, you've lost 10% of your brain volume. This brain volume loss, you might think it occurs later, but it's actually more accelerated when you're younger with multiple sclerosis. And so that process of loss of neurologic reserve occurs even before the clinical diagnosis. You can see with that clinically isolated syndrome or that prodromal syndrome, you're already losing brain volume. Most modern disease-modifying therapies have incorporated evaluating brain volume loss in their clinical trials. Even older medicines have been able to go back and do studies of their medications. But most modern MS trials look at this brain volume loss, and we see reductions close to, in that annual brain volume loss, close to normal age-matched controls. Has anyone heard of the term NEDA before? NEDA? Show of hands. A few nods. We call that no evidence of disease activity. There's different stages of that. There's NEDA 3, which is no relapses, no progression of disease, no MRI activity. And then there's something called NEDA 4, which means no progression of disease, no MRI activity, no relapses, and getting that annualized brain volume loss to less than 0.4% per year, or normalizing that. So that's one of our aspirational measures when we're looking at treatments. There can be different losses of volume in those different segments that I mentioned. So cortex and thalamus, losses of volume in those structures can predict cognitive impairment and can also predict disability accumulation. And I mentioned optic nerve has good reserve. Retinal nerve fiber layer, that's the back of the eye. We can see that shrink, and that's an indication of progression and disease activity. And then we're looking more at the cross-sectional area of the upper cervical spinal cord that we can see on a routine brain MRI, and measuring that to give us some information about neurologic reserve involving the spinal cord. So how do we preserve that reserve, that neurological reserve, and that cognitive reserve? Well, one of the most important things you can do is focus on a diet. And people ask me, well, what is the best MS diet? I don't have the answer for you for that. But when we look at preserving brain function in general and brain volume, eating a balanced, healthy diet, like a heart healthy diet or a Mediterranean diet, is a good start. And then we've learned that other things as we get older that damage the brain also drive cognitive impairment and neurologic disability and multiple sclerosis. And here's a list of them: high blood pressure, high cholesterol, diabetes, smoking drives disability progression. All these things hurt the brain. Excessive alcohol use can be toxic to the brain and cause brain atrophy. Obesity and sedentary lifestyle. And then in order to preserve your neurological reserve and your cognitive reserve, maintaining social experiences, your social network, cultural experiences, and then there's also cognitive therapy. So you can get plugged into a good therapist. Speech therapist oftentimes will do this, where they work on some tools, some cognitive therapy to exercise your brain, or we call it neurobics instead of aerobics, neurobics. So exercise, all right, that's a recurrent theme tonight. Energize, put good food and good fuel into your body, and socialize. Those are three key components to maintaining that neurologic and cognitive reserve. So what about these cognitive changes that happen in MS? So they occur commonly and early. I mentioned that at the diagnosis or the earliest onset of this, there can be cognitive changes. Usually it affects attention and concentration. Processing speed slows. There's a unique part of it where there's a loss of memory of experiences. We call it experiential memory. So you forget what you did. You forget that you had dinner with so-and-so. You have to be reminded. Age-related changes are delayed to recall. It just takes you longer to come up with the information, and eventually it comes to you. And there's an expected rate of change with this. So it's good to get a baseline. So having some form of cognitive testing is key, and then following that as you age and as you live with MS. And what about dementia? Dementia means loss of previously acquired cognitive function. Some studies show that people with MS may be at higher risk for Alzheimer's changes and may be at higher risk for vascular dementia or stroke-related dementia. There might be an overlap because we now believe that some of these neurodegenerative diseases other than MS are virally triggered. So there's viral demyelinating and neurological trigger, a viral trigger that may cause a cascade of events that lead to this. So that's probably a whole nother topic. Excuse me. Gait and mobility, considered a core component of MS. That's how we measure disability. It's heavily weighted in the later stages. We have this expanded disability status scale, or the Kursky scale. There's different patterns. Spastic with weakness relates to spinal cord changes, cerebral changes, brainstem changes. There's ataxia and imbalance, cerebellum and brainstem, foot drop. There's many complicating factors. Jeff gave us that great demonstration with his nice volunteer there, that in order to have good gait, mobility, and balance, you need your vision. So if with optic nerve or double vision from brainstem impairment, your vestibular function, brainstem, and sensation, spinal cord proprioception, you all need those things. Those change as you get older. So as you get older, there can be superimposed cerebrovascular disease that impairs the brain's ability to coordinate all this information. Peripheral neuropathy, maybe you've been exposed to steroids, which can maybe trigger diabetes, or there might be a family history of diabetes that can create changes in your sensation. Alcohol can impair the balance centers, can impair nerves. Medications. So medications, if you read the side effects, you'll see imbalance, dizziness. So it's critical to review the medication list and ensure there aren't medicines that are impacting that. There's spinal stenosis that can impair walking, degenerative joint disease, hip, knee, foot, ankle. Steroids can cause something called avascular necrosis. It can be of the knee, it can be of the hip, it can be of the shoulder, and that can cause gait and walking problems, vestibular disorders, and certain vitamin deficiencies. So it's important to look for those gold bars and find out if there's anything else complicating things. So you have to have a proper assessment. You got to talk to your healthcare provider. You get a history, a physical and neurological evaluation, laboratory studies. So about these gold bars. So when people tell me about their problems, and I think it might be age-related, I'm going to say, well, I'd really like to look at some other things. I'd like to do some labs. I'd like to do some x-rays. I'd like to maybe check an MRI of a part of your body that we haven't checked before. And if I get pushback, I'm saying, well, don't always assume that you're MS. Let's look for these gold bars. So laboratories, imaging, review medications. And oftentimes people have been on the same medicines forever and ever and ever, but they're older now and their kidneys aren't clearing them, and their liver isn't clearing them, and they're building up in their system. And then physio exercises, stretch, strengthen. Core strength is really critical, and devices to optimize biomechanics. I have a couple x-rays here I'd like to share with you. So on the, here's an x-ray of the hip. So here's and you can see here that there's a narrowing of the hip space, and there's a little arthritis in here. Look at this hip here on the right side. There's all this bony overgrowth. It's bone on bone there. That hip's getting fixed within that hip socket. And that could occur as a consequence of impaired biomechanics, the aging process. On this side, there's a lucency. You can kind of see these spots in here. That's from steroids. That's an avascular necrosis of the hip, and that can lead to a lot of pain and impaired mobility. Look at this spine here. Here's this curve there. So that's scoliosis, and it's going to change the biomechanics. Scoliosis, I used to get checked in school for that. They may bend over and the nurse would check you. I'm not sure they do that anymore, but I remember that. But that can occur later on in life. And in MS, when you have muscular weakness, there are muscles that run up and down the spine that are still supplied by those nerves that come from the spinal cord. If this part of the muscle is weakened, it's going to the stronger muscles are going to pull that spine over to the other side, and you can get a scoliosis from neuromuscular disease or from multiple sclerosis. The change in biomechanics with walking from MS can put undue pressure on the low spine and result in accelerated degenerative disc disease. So these spaces in between these bones are supposed to be much wider. There's these spurs off to the side, and you can see that there's narrowing. There's changes in the bone here from this degeneration and those normal cushions that occur. So mobility issues can occur in individuals with MS as a result of accelerated degenerative hip and spine disease, as well as scoliosis. There's something called spinal canal stenosis. So if you look on MRI, there can be a trapped group of nerves in the low spine. So MS affects the central nervous system. Here's the tip of the spinal cord. And then all of these are nerve roots. So MS doesn't affect this area. So sometimes people say, well, I was having these walking problems and my doctor ordered a lumbar spine MRI and they didn't see anything wrong. But the problem in MS was higher up. And so this is a normal canal and it gets squished. And this can occur in MS due to using a walker all the time, being bent over, having weakness, loss of core muscle strength, and it destabilizes the spine. The symptoms of that are ambulatory problems, pain in the legs with walking, and weakness, so it can mimic or overlap with the MS symptoms. Here's the same thing, but in the cervical spine. So there's this arthritis here, which is pinching off the cervical spinal cord, and you can see a lesion in the spinal cord, which is not an MS lesion. And so that's another pitfall, that people have worsening of their walking. They have MS, but now they have regular old cervical spinal canal stenosis. That's a surgically fixable and treatable condition. So the management of gait and mobility issues, you want to identify the underlying cause. You worry about, is this multifactorial and other related issues, and then you get the appropriate referrals. If it's a hip, see the orthopedist. If it's a spine, see a spine specialist, neurosurgeon, or a physical therapist can help with the biomechanics and adapting and strengthening your core. If MS is a primary cause, you could consider pharmacologic intervention. There's a medicine that helps people with MS walk better, or use assistive devices, either electrical or certain shoes or foot braces or mobility devices, and then get plugged into a good physical therapist for assistance with that. So let's switch gears a little bit. We'll look at the aging immune system. So when does this happen? I was shocked to learn that 45 is when the immune system starts going south and getting weaker. So we call that immunosenescence. So its roles in disease include, you're more prone to infection. So your risk of infection is higher, the rate of infection is higher, and the severity of infection is greater. And so what do you do to try to prevent some of these infections? You go and you get your appropriate vaccines, but the response to the vaccines are less robust. So you see there's different recommendations for different vaccines at different ages. So you get a higher dose or flu shot if you're older. You get a special pneumonia shot when you're older. When I turned 50, my birthday present to myself was to get the Shingrix vaccine. There's a robust response to that. But we do see that as we get older, there's that risk of infection. What else does the immune system do as far as protecting us? Probably every day there's 1,000 new mutated cells in our body. Most of those happen on places that are exposed to the sun. So we get these skin malignancies, these cancer cells that develop. Our immune system weeds those cells out. It recognizes them, it gets rid of them. But as we age, we see more malignancies and more cancer. That's why our immune system is there to help us. I mentioned that inflammaging. So there's also this low-grade, not helpful, detrimental inflammatory response that limits our ability of the rest of our immune system to act quickly and appropriately. And then with MS, there's an impact of the disease-modifying therapies on the immune system. So a lot of these medications and therapies are designed to dampen down or wrangle in an aberrant, overactive, misdirected immune system. But over time, it can have impacts on that. And then sequencing of those medications can have an impact on the aging immune system. So here are our take-home points. And I just want to just hammer home that there's two distinct processes that occur early in MS. It's not that inflammation occurs early and neurodegeneration occurs later. These occur simultaneously from the onset. There's an effect of aging on MS, and MS influences age-related changes. So it's difficult to separate the two, and it takes a little bit of digging those gold bars out. Do not assume it must be the MS. As you get older, that is less and less true. And that really highlights the importance of getting a proper assessment and doing the right things. And what can we do about it? The critical thing is there's a role of lifestyle. So exercise, diet, and maintain your activity. So remember, energize, socialize, and exercise. And that's the final slide. Yeah, and I really want to thank you guys for your attention. I hope it was somewhat helpful. Am I overtime? Am I under time?
You're perfect.
Perfect. Thank you, Stuart. Okay.
Everybody give him a round of applause. That was awesome. Okay. If I were them, I'd be standing up giving you an ovation.
Thank you. Thank you.
Okay, it was very good. Thank you.
I noticed you're moving better. You look younger and you're moving better.
I don't stop moving.
Okay, yeah.
That's the problem. Is I have to keep moving
Those-
to keep moving.
It's hard to hit a moving target.
That's exactly it. All right. But I do have a ton of questions online. All right. These people want to know more. And I'm going to go to this one first because I think it is quite important. We older MS patients, 70 years plus or more, are we statistically going to live 7 years less than the normal population?
The last I checked, that's an accurate number. It's 6 to 7 year reduced lifespan overall, but that has decreased. It used to be a lot higher, and I think in the U.S. and this changes year to year, but I think in the U.S. the age for a woman, the lifespan might be 82, and maybe for a man 80. So if you're 70 and your age is reduced from 82 to 76. Now, that's just, these are all statistics, and so statistics applies to a population of people. It doesn't apply to the individual. So we don't have a crystal ball, but the lifespan of the person with MS has increased, and we think that might be due to better access to healthcare, maybe more recognition of things like this, identifying comorbidities, treating them, recognizing that MS people get cancer too, MS people get heart attacks, and so by addressing those, we can increase the life expectancy. We do think that the impact of DMTs has increased life expectancy as well.
Okay, thank you.
Oh, disease-modifying therapy. So,
okay. All right. Next one from online. Why am I excluded from clinical trials because I'm 63? Trials should be more inclusive.
I agree. I think I call it ageism. I think it's unfair. Now, if you're running the clinical trial and you've designed this, here's the reason. Well, first in MS, our endpoints, what we were measuring were relapse activity. And we knew from natural history that the older you got, the fewer relapses you got. So when you're designing a trial, you want to you want to study a population where relapses are more prominent. The other part of it is you don't want us old guys in your trial that are going to have a heart attack or a stroke or develop cancer in the clinical trial, and then you're going to get dinged for that. So part of it is having a relatively healthy group of people without other issues so that you don't get adverse effects in that trial and you can demonstrate a benefit of whatever you're studying. Some trials go to age 60, some to age 65. So they're expanding that, especially in trials where we're looking at non-active secondary progressive multiple sclerosis. But I thought it's unfair. As a practicing MS doctor in Southwest Florida, and one who does a lot of research, I want to have those sort of things be accessible to my patient. We just did a remyelinating trial, and they cut it off at age 50, not 55, and it made sense because that remyelinating capacity goes down. They wanted to see a signal. So.
Is it also because of the comorbidities?
Yeah, the comorbid. So any other medical condition that could be driving, or so for instance, when someone's in a clinical trial, they can start a medication and then their blood pressure goes up. That becomes an adverse effect. It may have nothing to do with the drug or the placebo, but you have to document that it increased. And then when the FDA looks at this, they say, well, we saw these adverse effects. We might not think that the drug is safe and may cause these side effects.
That's right. Question.
Is it possible to have secondary progressive MS and be NIDA? And what is NIDA for? You described it, but how do they measure your brain reserve?
So brain reserve is... So in clinical trials, there's very fancy. Let me see if I understand, if I don't answer your question right, maybe just let me know. Brain reserve is related to in part to brain volume, In clinical trials, when you do the periodic MRIs, they use computer software to trace lines around the edges of the brain and the insides of the brain, and they can calculate down to the 10th of a milliliter the volume of the brain. And so they usually do a baseline, then they'll do one maybe at 3 or 6 months, and then they do one at the 2-year mark at the end of the trial for brain volume. The 6-month one is usually your baseline for brain volume, because if there's inflammation in the brain, that's going to increase the brain volume. So you could treat MS, reduce inflammation, and from baseline to month 6, you could see the brain shrink. It doesn't shrink because the brain's getting smaller. It shrinks because you've reduced inflammation. So we call that pseudo atrophy. But if you take it from 6 months to the end of the trial, you can see what the true atrophy rate is, or at 1 year and 2 years. So that's how they measure that in clinical research. Now here in my standard of practice is we get MRIs that include brain volume as a measurement. And so that's a nice bonus, and we can look at that and we can follow it throughout the course of treatment. Did I answer that question? Was that? Yeah.
Does the report from the radiologist suggest brain volume? Is that written in a report?
So in your average MRI report for MS, it's going to say, it'll usually say lesions consistent with MS, differential diagnosis is migraine, small vessel disease, or combination. And they may make a comment about brain atrophy or brain volume. So they may say something like global or central brain volume loss. In our reports, I can see the total brain volume. I can see the segmental volume of the thalamus, of the brain cortex, and I can see what the change was. I can see the percentile, how that matches up with age-matched peers. Is it in the 50th percentile, first percentile? And I can see how it's changed from the year before or from 2 years before. So that's special software. And then I put that in my report so that I can remember that that's what's occurring. If there's been a substantial change for the more accelerated brain atrophy, that might clue me into talking more about lifestyle modification, exercise, maybe thinking about changing disease-modifying therapies if someone has complaints of progression or if they have complaints of cognitive changes. And that might make me lean towards maybe a molecule or a disease-modifying therapy that might get into the brain more as opposed to staying outside the brain. So it has some therapeutic value for me in my clinical practice.
How do we limit or slow down brain volume loss?
So one would be, if it's appropriate and it's right for you, pick the right disease-modifying therapy to get on. That's one thing. So we know that these disease-modifying therapies can slow brain volume loss. And so that for me is part of it, if it's appropriate for that individual. Exercise is critical. Staying hydrated is critical. So eating a healthy diet and avoiding things that are toxic to the brain. There was a really interesting study that was done in people with MS, and they randomized them to two arms. One arm was scheduled daily aerobic exercise. I think it was at least 40 minutes a day of aerobic exercise. And it could be chair exercises, just getting your heart rate up. And the other group I called the couch potato arm. They just said, don't do anything, just sit on the couch. And they took a baseline MRI, looked at brain volume, and they looked at 6 months and they looked at a year. And it was amazing that at the year mark, the people that engaged in routine exercise had an increase in their brain volume. They grew back some brain. And the people in the couch potato, they had the same accelerated brain atrophy that we would expect to see. So those are some key things for maintaining brain volume, or maybe even, according to this study, you could increase your brain volume.
Okay, thank you for that. Next question is, do you primarily prescribe 3T MRI, and why?
I do. I like to keep it consistent. I think it gives more detail. You can see, so when you look for MS lesions, you look around the ventricles, which are the fluid-filled spaces of the brain. You look under the cortex, we call those subcortical lesions. You look in the brainstem area, or under the tent, that's a structure, or infratentorial, that separates the top part of the brain from the bottom part of the brain. And then you look for lesions that are right up next to the cortex. But there are also some other things that occur. There are lesions that occur within the gray matter. So we call those intracortical, or in the cortex, intracortical lesions. So those high field magnets with certain sequences, you can actually see demyelination within the brain cortex. And so having that 3T helps. Also, the 3T magnets that we have in Southwest Florida, they have that software that I can look at brain volume. And then I just like to compare apples and apples. But there are really good 1.5 Tesla scanners that show very vivid detail. It's all how the software is set up. There's also some very good high field open MRIs. So I'm okay with those two, but I prefer 3T overall.
Two questions. First, on the one chart where you had the reserve and the disability, looking at that chart, it looked like, is it safe to assume that everybody with MS, eventually their disability is going to get worse? First question. And then second question, what's the latest news on the BTK inhibitors?
So first question, that's just sort of that graph doesn't mean everybody. That's kind of an example of different scenarios. So our goal is for people not to get worse. And I think on some people will get to a certain point and they plateau and they don't get worse. And then certain people who get on a medication that works for them, we don't see substantial disability worsening. And if you look at some of the long-term extension data from the trials, you see very little disability change in those people that find the right medicine that they can stay and stick on, as long as they do the other things too. The lifestyle and the exercise is important. Now you asked, the second question is, what's the latest on the BTK inhibitor? So just for people who haven't heard this term before, BTK inhibitors are a class of medicine, and it stands for Bruton tyrosine kinase inhibitor. So Bruton is the guy that described it in his name. A tyrosine kinase is an enzyme, and those enzymes dictate cellular function. And there's all sorts of different forms of tyrosine kinases. Bruton tyrosine kinase is present on B cells, on B lymphocytes, but also present inside the central nervous system and expressed highly in a special cell type that we call activated microglia. So these are inherent cells inside the central nervous system that drive inflammation, and we think play a role in progressive disease. And so our hope is that this class of medicine, and there's several that are being investigated, this class of medicine will act peripherally outside the central nervous system on B cells that drive MS, but also are small molecules that get into the central nervous system that address this slow smoldering process that is driving disability progression. So it has these compounds are very attractive for the treatment of progressive forms of multiple sclerosis. So the latest update is that there was one that was studied, and in the relapsing form, they compared it to a medication that's already approved called Aubagio or teriflunomide. It did not separate from that. Both drugs worked, but it wasn't superior. It didn't meet its endpoint. So they stopped that trial, and they aren't pursuing commercialization or FDA approval of it. There's a second drug called tolebrutinib. All of these medications in something IB or brutinib, so Bruton tyrosine kinase inhibitor, so ibrutinib. So tolebrutinib is being studied in relapsing forms of MS, but also in non-active secondary progressive MS. And they had a readout on that data. And what they showed was that it did slow disability progression in non-active secondary progressive MS, which is big news because we don't have a drug that addresses that part of the graph that I showed you, that part of the figure. And so I think there's some discussions. The FDA has the data. They're looking at it. There is a issue with that drug with elevations in liver enzymes and liver toxicity. So there will probably be a monitoring requirements if that drug gets approved, so that they're sorting that out. And that's not new to MS medicines. So in certain MS medicines, there are programs where we have to look at safety and we have to collect data. You can think about natalizumab has a REMS program, very good medication. You have to be enrolled in a REMS program. There's monitoring required, allows us to collect data. Alemtuzumab or Lemtrada has a REMS program. And when Aubagio was launched, and we know that when you first start it, you have to check liver enzymes monthly. But the frequency and the duration of liver monitoring, should this medication get approved, hasn't been established yet.
People want to know if you can talk to them about the psionic sleeve.
I think that's a great device to help with mobility. I think access to the psionics, what I like about it is it's pretty streamlined. So for those of you who don't know, there are assisted devices for gait and ambulation, which are electrical stimulators. So they're nerve stimulators. And sometimes it's hard for people who don't have MS to kind of wrap their heads around the fact that this is a central nervous system problem. And so the signal isn't getting from the spinal cord down to the foot or the leg. But outside of the central nervous system, the peripheral nerves are completely intact and functioning. So if you can detect a movement in the leg, and you have a device that can time electrical stimulation of the nerves into the leg to contract that muscle, you can improve mobility. So I would encourage people, if they have gait and mobility issues, work with the physical therapist, work with their neurologist, see if that's an option, see if that helps them, and then pursue that.
Thank you. And the sleeve was just FDA approved.
It's been approved for a while, I think. Yeah.
Yeah.
At least within the last year, I think.
But it costs a fortune to change the parts.
Well, that's interesting. So, I have a friend that's a BMW mechanic, and he says, well, they're going to make all these BMWs that have every single option on them. And then what you do is you just pay a monthly fee if you want your seats heated. If you don't want them, they just don't turn them on, but they made all the cars the same. And so I think these devices are similar to that, in that you can get the device, but there's sort of a monthly charge for kind of adjusting and adapting and things. So that's a problem with access to these they cost as much as a car sometimes, or the monthly fee to maintain them is as much as a car payment. Then you just have to decide what's in your budget, what's important. We'd love to see better coverage for it.
Is loss of executive function just a combination of other issues, or is it a separate pathology?
So when we think about cognitive impairment, there are different realms of cognition, and So there's speech and language, there's memory, and then within memory, there's different types of memory. There's episodic memory, there's recent memory, there's remote memory, there's attention and concentration, comprehension, and then executive function is sort of those frontal areas, the frontal parts of the brain that allow you to make good decisions and think about things and rationalize things and plan for things. And so that executive function in certain cases, that's not one of the typical MS-related cognitive changes. However, if there is prominent involvement of those brain structures, which can happen in MS, you can have lesions that affect the frontal lobes and the frontal cortices, and so in those situations, you can see impairment in executive function.
I have, you're not going to be, I don't know if you're going to be happy with me or not, but I have made this decision to not take my disease-modifying drugs. Then, I have now read many articles that say people should stop taking them at a certain age. Some of them say 70, some say 75, and I'm over 75. Is that true?
Well, first of all, Karen, I could never be unhappy with you. Secondly, I love you.
Thank you.
Third, that is a great statement and question, and we're learning about this, but it's really a hot topic. And so, should you stop your MS medicine? If so, at what age? And then what is your risk? And so there have been a couple of studies that have looked at this. One study is a discontinuation study, and people were randomized to either continuing their medicine or stopping their medicine. And it was designed differently because we call it a non-inferiority study. So they weren't saying one is better than the other, but they're just saying one isn't any worse than the other. And so you have to set your limit, and you sort of say, well, what are we willing to accept? And so if you're willing to accept that maybe you're going to get one new MS spot on a follow-up MRI, but no relapses, no disability progression. It appears that in a certain group of people, being off of medicine isn't any worse than being on medicine. And then there's another study that looked at discontinuation, and what they found was that about a third of patients who went off of their medicine, they had progression of disease, but 2/3 of patients did not have progression of disease. So it's an individual decision that you make with your neurologist. I look at this, I look at no disease-modifying therapy as a therapy. And that sounds strange, but if someone says to me, I'm over 65 or 60 or whatever it is, and I haven't had any disease activity, I haven't had any MRI lesions, I've been pretty stable on my medicine. For whatever reason, I don't think I want to be on medicine anymore. I haven't had any relapses. Can I come off? I said, yes, but this is our new treatment. You're coming off of medicine. I want your treatment now is healthy diet, lifestyle, and managing comorbidities and risk factors. We're going to look at healthy living, and we're going to do an MRI, and we're going to do our baseline. Anytime you switch treatment, you're going to get a baseline MRI, and you're going to look at that MRI in 6 months or a year, and you're going to see if what you're doing is right with that specific treatment. There's also something that I'm using. It's a biomarker test, and so it looks at different things in the blood that tell us about the likelihood that you'll have an MRI lesion. And so getting a baseline before stopping, and then maybe checking that. It's just a blood test. It's a simple blood test. 3, 6 months, every 3, see what happens. If we see a change in that, it means that maybe you need to be on something to modify the disease process. Now, the caveat there is in some of these discontinuation trials, you have to look at what medicine they were on. So if they were on an older, we call these platform therapies, and their disease did not require a high efficacy medicine, or they'd been stable for many years on the platform therapy, maybe their disease is different. Maybe it's not as active. So if you have people who are on more highly effective treatments and discontinuing those, you might see disease activity because their disease was more active to begin with. Another thing to mention is that there's a medicine, fingolimod. It was formerly known as Gilenya, now it's generic. That medication has been associated with what we call rebound activity. So when you stop the medicine, there can be an overshoot. That medicine's been around, I want to say 14 years or so. And so the people that I started on that medicine when they were 45 are now older. They're older individuals, and stopping that medicine, they might go back to the disease they had when they were younger, and you see increased disease activity. So you have to be cautious with that. Highly potent medicines like natalizumab, if you stop that, there can be return of disease activity. Those people were put on that medication way back when, because we did that for people who are having breakthrough disease on older medications. So the bottom, that's a long-winded answer. The bottom line is it's very individualized. It's a discussion with your healthcare provider. You have to balance the benefits of the medicine, the risk of coming off, and the risk of staying on as you get older. But there are certainly ways to mitigate that risk and follow it. But I'm not mad at you. I think had we had a discussion, we probably would have come to the same conclusion together.
Thank you.
Thanks,
One last question. It's getting late. We got to take one last question.
Hello, Dr. Baker.
Hello.
Just curious about the CDP choline that was improving the myelin regeneration. Is that all done? I know it was like a 2021, 2022 study, but how are they doing with the myelin regeneration studies? Maybe the PIPE?
Oh, the PIPE,
yeah. Or one of any of the other ones, because I know there was a CDP choline study.
These are emerging studies, and we're going to get some more data on that. So I don't have anything to report to you on that. I don't specifically know the CDP choline study. I know the PIPE study completed enrollment, which is exciting. So they got enough people in. So hopefully we'll see some data on the patient demographics soon. And it's a short study, so we should see some results probably within a year. So.
Awesome. That's it. We're going to call it a wrap, all
Hey,
right?
thank you, Stuart.
Thank you.
Thank you, everybody.
Thanks for being here. And for all those that are still here, I just want to thank you for being here. And we hope that you check out our YouTube channel, because there are many doctors that speak for us, whether it's in person, virtually, everywhere. All right. It's just that we have a lot of people speaking all the time. They all want to make sure that our patient base are learning as much as they can about multiple sclerosis so they could live their best lives with multiple sclerosis. So again, if you're not looking at what we're doing, you need to be looking at what we're doing. Okay. Thank you.